So when we look at the multifocal hemangiomas, if you do ultrasound or MR, and you look during the proliferative phase, like with other infantile hemangiomas, what you see is dependent on the phase of the life cycle. And during proliferation, you can see these cannonball lesions are hypointense on T1, hyperintense on T2, and this is a T2 fat sat, and certainly avidly take up contrast. And on ultrasound, usually they are somewhat hyporeflective in relation to the normal liver parenchyma. The focus on MR actually obviously are again hypointense on T1. On these coronal images you can see some heterogeneity actually on the T2, but somewhat hyperintense with some peripheral enhancement with contrast. And if you did a dynamic scan, you might see some infilling as you would expect. And this group are the so-called or the thought perhaps to be equivalent of the Riche type lesions. And the Riche, this central area where there is no enhancement, and no enhancement whether you did a CT scan as here, and no enhancement on MR, is because the central portion of this is clotted, it's thrombus in it, it's like a large varix, and it doesn't take up the contrast easily. And on ultrasound, sometimes you can see areas of calcification in a somewhat heterogeneously hyperreflective lesion. When we image these children with any of the hepatic hemangiomas, what we really need to look for is evidence of shunting. We'll know clinically they'll be shunting if they're in cardiac failure, there is no question about it, but what as radiologists do we need to look at? And obviously we assess the lesions themselves, and then we're looking for evidence of shunts, because shunts can lead to cardiac failure. So what we want to do is to look at change in size of the aortic caliber above and below the celiac trunk. You can see this on any modality. I don't need to go through all of this with you, I'm certain, but yeah, I can assure you on this you can see the diminution in caliber of the aorta above and below the celiac trunk. So here is the level of the diaphragm. The common hepatic artery here is enlarged as well, and you'll see evidence of shunting giving rise to enlargement of the hepatic veins in the liver because there's more blood flow through them, and you see this angiographically as well. And angiographically you can see diminution in size of the aortic caliber above and below the celiac axis. And this does show you how sometimes it can be very difficult babies if you have to intervene interventionally to actually get a catheter up from the femoral up into this small caliber aorta, and once you're there you've got to try and turn it within the aorta, and that makes it life sometimes challenging, and occasionally you'll have to come down from the arm as well as tackling an approach from the leg. Now the angiograms, we don't, because a baby has a hepatic hemangioma, it doesn't mean we have to do angiography. We would do angiography as part of the embolization procedure if these infants were in cardiac failure. And there are a variety of patterns that you can see, from areas of hypervascularity, puddling within the liver, hypervascular nodules and drainage into prominent hepatic veins, hypervascularized nodules without drainage, arteriovenous connections, arterial supplies from areas we may not expect sometimes, like intercostal arteries. These lesions, the hepatic hemangiomas, can recruit arterial supplies. They don't just get an arterial supply from the common hepatic artery, they can come from the internal mammary, from the phrenics, the renals, intercostal. So at times it can be quite challenging when we are limited by the dose of contrast that we use as well. And also you can see there's large hypervascular areas which drain into enlarged veins. You can see spontaneous portosystemic shunts between the portal vein and hepatic veins in hemangiomas. And you can see also the catheter here is in the hepatic artery. Here's the right portal vein filling. So we've got a direct shunt without parenchymal filling, is much in from the hepatic artery, portal vein, gone into the hepatic vein. And so it can be quite complex, all these patterns, and because of that there's been a recommendation to provide an angiographic classification of intrahepatic hemangiomas. So those into two groups, those exhibiting no shunts and those exhibiting direct shunts. So there's two types, showing early abnormal channel filling and pooling, and type 2 with high flow nodules and early hepatic vein filling. And then with the direct shunt type, either the shunts can be arteriovenous, including arterioportal, venous or combinations of portovenous and arteriovenous. So there's various different types of shunts, and here are some of the angiographic patterns. You can see with a type 1 where there's no shunt with this pooling of contrast, type 2 again with no shunt but hypervascularized nodules and early draining into prominent hepatic veins. And then with type 3 you may identify some shunts, but sometimes it can be difficult, but what you see is early drainage into enlarged hepatic veins, implying a hepatic artery to hepatic vein shunt. You can easily identify on an SMA arterioportogram portovenous shunts within the liver, and also you can display on arterial injections a multiplicity of shunts as I described. So there was a proposed treatment algorithm by the group in Boston actually some time back as to what you do to treat hepatic hemangiomas. And really the take-home message is first of all define whether they have a focal, multifocal or diffuse hemangioma. Then decide, do they have shunts or not? Know whether the child has got abdominal compartment syndrome, and if they've got an abdominal compartment syndrome, always measure the thyroid stimulating hormone level, because the TSH level may often be extremely high, and one way to improve the outcome is to give them massive doses of thyroxine. And then, if they have shunts and cardiac failure, as well as putting them on steroids and angiogenesis inhibitors, consider early embolization if things are really not improving. Do not wait 4 or 6 weeks, for example. You might have to wait perhaps 2 weeks to see if there's some steroid improvement, but really, nowadays, even since this paper has been written, and I know the group very well in Children's Hospital of Boston, that in fact they would embolize early if the child, for example, was intractable cardiac failure. They put them on the steroids and they could try and get the embolization done. You're doing the embolization to close the shunts. So you can close some of these lesions, the infantile hemangiomas, with a variety of embolic agents, and if there's not significant shunting, you can actually reduce some of this hypervascularity. And usually, if you haven't got shunts, you don't have cardiac failure. But interestingly, this baby did have a mild degree of cardiac failure, and we did the embolization here. You can see the aorta above and below the celiac trunk. There's a pigtail in the aorta, and the hepatic artery is enlarged. And there's most of the liver is very hypervascular due to the multiple infantile hemangiomas, I should say. And we could actually get a 4 French catheter just into the hepatic artery here. And actually, at that point, in fact, we advanced it slightly further. We actually put in PVA. You don't really need to be super selective to do that in a way, unless you actually are concerned about the portal vein supply to the liver, because if you actually have significant portovenous shunting and you do an arterial embolization, then the liver will not actually derive supply, its parenchyma will not supply from the portal vein if there's lots of portal vein to hepatic vein shunts. So you might, and you'll render the liver ischemic. So you might actually want to just do an embolization of part of the right liver, and maybe a week later or a few days later, depending on the clinical problem with the child and the urgency, take off a little bit more of the liver, and you can do it in a staged fashion, maybe every few days or every week. So we always want to reiterate that when you do an arterial embolization, know what the portal vein supply is like, and are there portovenous shunts as well.